This is Nguyen, and today we're going to be talking about trauma anesthesia as well as burns. So some statistics to start off with. Unintentional injury is the leading cause of death in people ages 1 through 45 years of age in the U.S. Overall, trauma is the third leading cause of death with an estimated 181,000 deaths per year in the U.S. Most common cause of death in the U.S. is heart disease, with the second being cancer. Approximately 75% of the hospital deaths from motor vehicle collisions, gunshot or stab wounds, and falls occur within 2 days of hospital admission. Most common causes of early trauma mortality are due to hemorrhage and CNS injury. Advanced Trauma Life Support, also known as ATLS, the course by the American College of Surgeons, is the most used training program for trauma physicians of all disciplines. The initial management strategy can be thought of as a continuous, priority-driven process of patient assessment, resuscitation, and reassessment. It's broken down into the primary survey as well as a secondary survey. So what goes on in this initial evaluation? The first thing we do is the primary survey. It's a real quick evaluation of the crucial functions. Essentially the ABCs plus D and E. So A is for airway patency. If the patient's obstructed, do chin lift, jaw thrusts, obviously with C-spine immobilize during this maneuver. B is for breathing. Is the patient oxygenating and ventilating adequately? If not, you may have to proceed quickly to a rapid sequence induction. C is for circulation. You should look for signs of shock, such as hypotension, tachycardia, pallor, as well as altered mental status. During this stage, LAPS and 2 large bore IVs should be attained and resuscitation is started. Blood should be also sent off to be typed and crossed for a couple units. D is for disability / neurologic assessment, also known as the GCS. E is for exposure. Completely undress the patient to rule out other injuries. During this process, it's prudent to keep the patient warm to prevent hypothermia. This primary survey is also meant to identify and treat life-threatening injuries, beginning with the most severe ones first. How about the airway evaluation? The initial steps in airway management are, like we talked about, chin lift and jaw thrust, while at the same time stabilizing and immobilizing the cervical spine. Supplemental oxygen should also be provided. The adequacy of oxygenation and ventilation obviously dictates the urgency of securing the airway. If oxygenation and ventilation are inadequate, gently ventilate if necessary with cricoid pressure, followed quickly by rapid sequence induction, obviously with cricoid pressure and inline stabilization. If a difficult airway is anticipated and oxygenation and ventilation is marginal, there may be time to topicalize the airway and perform an awake fiber optic intubation. Always have a cricothyrotomy kit available, as well as the personnel around that can perform one in case the airway cannot be secured in a quick fashion. More about the airway eval. Treat all trauma patients as full stomachs. Maxillofacial and neck injuries, as well as cervical facial burns, are the most common trauma-related causes of difficult intubation. If a patient has a basilar skull fracture, or if you suspect a basilar skull fracture, a nasal tracheal tube is contraindicated. 2 to 4% of blunt trauma patients have cervical spine injuries, and of these, 7 to 15% are unstable. If you're suspicious for a C-spine injury, CT scans can rule out the majority of injuries. However, these CAT scans are not sensitive enough to rule out ligament injuries. If you suspect the ligament injury, the scan of choice to rule it out is an MRI. Once you're done with the primary survey, you proceed to the secondary survey. Secondary survey is a more intense systematic exam to uncover and identify additional injuries, essentially a detailed head-to-toe exam of the patient. Radiographic studies such as x-rays, chest, abdomen, pelvis, and the FAST are also performed at this time. CAT scans are performed depending on patient stability. Numerous injuries are possible, but some common ones that we see are TBI, traumatic brain injury, neck injuries involving the vascular and airway structure damages, pneumothorax, aortic injuries, liver and spleen lax, as well as pelvic injuries. It is important to note that many injuries can be missed during the initial evaluation, and to remember this when the patient is in the OR, as cold injuries can be fatal. So always have a high index of suspicion for certain injuries depending on the mechanism of the injury. So what is a FAST exam? It stands for Focus Assessment with Sonography for Trauma. It screens for fluid, mainly around 4 areas. Number 1, the heart. 2, the liver. 3, the spleen. And 4, the pelvis. FAST exam. What defines a positive FAST? It's defined as a dark strip, which usually represents free fluid or blood in the dependent areas of the peritoneum, usually in a supine patient. So in the right upper quadrant, usually shows up in Morrison's pouch, which is the area between the liver and the kidney. In the left upper quadrant, blood can show up anywhere around the spleen. In the pelvis, blood usually pulls behind the bladder. If the FAST is positive and the patient is stable, CT scans usually follow. If the FAST is positive and the patient is unstable, the patient usually goes straight up to the OR. So what are some common complications we see from trauma? One of the most common and one of the most lethal complications is traumatic brain injury. 40% of deaths from trauma are caused by head injury. Traumatic brain injury is classified as mild, moderate, and severe. And this is based on the patient's initial presenting GCS, Glasgow Coma Scale. For mild traumatic brain injury, patients present with a GCS of 13 to 15. For moderate traumatic brain injury, the GCS is 9 to 12. Severe traumatic brain injury is classified as a GCS of 8 or less. As you can see, the Glasgow Coma Scale is based on best eye response, best verbal response, and the best motor response. The most feared consequence of a head injury is ischemia of the brain. With patients with traumatic brain injuries, an important goal is to prevent secondary injuries such as intracranial hypertension, which is due to cerebral edema related to the head injury. Hypoxia and hypotension are very detrimental to these patients. So your goals, if you take care of a patient in the OR with traumatic brain injury, are normalize the intracranial pressure, optimize cerebral perfusion pressure, and we remember that cerebral perfusion pressure is the mean arterial pressure minus the ICP. And lastly, optimize oxygen delivery. You should aim for a mean arterial pressure of greater than 80, a PaO2 of greater than 95, an ICP less than 20, and cerebral perfusion pressure of 50 to 70. Hemorrhage. It's obviously another complication from trauma that leads to a lot of morbidity and mortality. Hemorrhage is the most common cause of traumatic hypotension, and after head injury is the second most common cause of mortality. High energy deceleration impact High-velocity gunshot wounds and falls from heights greater than 6 meters are highly likely to produce major bleeding and damage. Most common places for occult bleeding resulting in hypotension is in the thorax, abdomen, and retroperitoneum. Rapid operative treatment for damage control is key in patients with hemorrhagic shock. What happens when you take a trauma patient up to the OR? First thing you should do is warm up the OR. Turn the thermostat to max, turn the bear hugger on, and warm all your crystalloids and blood products. Once in the OR, all patients should be treated as C-spine precautions unless they are cleared. If a patient is not already intubated, perform rapid sequence induction with inline stabilization. Rapid sequence induction can be performed with propofol sucks or etomidate sucks depending on the stability of the patient. Attain large bore access if not present, preferably 216s or a couple RICs. Have the level 1 or rapid infuser systems hooked up to your large bore access. In terms of access, place arterial line for close monitoring of blood pressure and frequent labs. Depending on the projected needs of vasoactive agents or lack of adequate peripheral access, central venous line access should be considered. Baseline labs that should be sent off include arterial blood gas, lactate, coags, fibrinogen, and a platelet count. It has been protocol for our Blue Surgery Service here at UK to send tags to monitor coagulation status. Other drugs that you should have in the room and ready to use are epinephrine, bicarbonate, and calcium chloride. In stable patients that come to the operating room, ask for 2 to 4 units of type-specific blood to be in the cooler when it becomes available. In unstable patients that come straight to the OR and do not have type-specific blood available, activate the massive transfusion protocol with the blood bank. The purpose of the massive transfusion protocol is hemostatic resuscitation. It emphasizes maintenance of blood composition through early transfusion of packed red blood cells, platelets, fresh frozen plasma, as opposed to infusing large volumes of crystalloids, which worsen coagulopathy through dilutional effect. So here at UK, our MTP, the Massive Transfusion Protocol, first cooler will contain 4 packed red blood cells and 2 fresh frozen plasma. After this is done, and the patient is still, if the bleeding is still not under control, a second cooler will arrive with 4 packed red blood cells, 4 fresh frozen plasma, and a 6-pack of platelets. This will continue with cycles of coolers until the blood bank is notified that bleeding is controlled. It's prudent to check coags, fibrinogen, and hemogram after each round of the massive transfusion protocol. So what is a triad of death? In trauma patients, there's a group of interrelated conditions that leads to death. The known triad consists of hypothermia, coagulopathy, and acidosis. As these patients become more hypothermic, they become more coagulopathic. The coagulopathy makes the bleeding worse. The increased uncontrolled bleeding in turn worsens the metabolic acidosis as the body cannot keep up with the oxygen demand. This acidosis also makes the coagulopathy worse. As this cycle takes over, it's a vicious downward spiral. So that's why it's so important to keep the patient warm and the room as warm as possible. So how do we resuscitate these patients? There's a concept of permissive hypotension in trauma patients, obviously excluding trauma patients with traumatic brain injury or spinal cord injury. And in those patients, you want higher perfusion pressures to perfuse the brain and the spinal cord. Studies have shown that Patient outcomes are better when a lower mean arterial pressure, aim for around 60, is its target, as opposed to a higher mean arterial pressure. Another reason to avoid aggressive fluid resuscitation is that it leads to dilution of coagulation factors, platelets, and packed red blood cells, as well as increased bleeding due to the increased blood pressure. So, goals for resuscitation in a trauma patient. Systolic blood pressure, 80 to 100, unless, like we talked about, if they have traumatic brain injury or spinal cord injury. A core temperature of greater than 36 degrees Celsius. A hematocrit of 25 to 30%. Normal coags, INR, PT, PTT, all within normal limits. A platelet count greater than 50,000. Normal ionized calcium. You should keep a close eye on the calcium level, as the citrate, which is an anticoagulate in blood products, can bond calcium and cause hypocalcemia. Of all the blood products that we administer, FFP is the one that has the most citrate. And lastly, correct acidosis via improved perfusion. So let's switch gears and talk about burns. Resuscitation guidelines, as well as indications for surgical interventions for burns, are determined by the size and depth of the burn. You have various degrees of burn. We'll start with partial thickness. It's defined as it's red, blanches to touch, sensitive to pain and heat. The next stage is superficial partial thickness, also known as first degree burn, and involves the epidermis and upper dermis. Second degree burns, which are deep partial thickness, involve the deep dermis and require excision and grafting. Third degree burns, which are also known as full thickness burns, don't blanch or are insensate. The dermis is completely destroyed and the patient requires wound excision and graft to prevent wound infection. Fourth degree burns involve muscle, fascia, and bone. So how do we quantify how much of the body is burned? Called the rule of nines. Okay, for adults, the head is considered 9% of total body surface area. The upper extremities are 9% each. Trunk is 36%, with the front being 18% and the back being 18%. The lower extremities are 18% each. So using these rule of nines, you can calculate the total body surface area that is burned in a patient that is burned. What are major burns? Classified as full thickness burns greater than 10% of total body surface area. Partial thickness burns greater than 25% of total body surface area in adults, or over 20% at the extremes of age. Also, burns that involve the face, hands, and perineum. As a result of severe burns, stimulates mediators such as interleukin, tumor necrosis factor, leading to immune suppression, hypermetabolism, insulin resistance, sepsis, protein catabolism, and multisystem organ failure. What are some associated injuries with burns? Knowing the mechanism of injury can help figure out these associated injuries. So burns from MVCs or industrial accidents can be associated with other traumatic injuries. Electrocution burns may be associated with hematomas, severe fractures, skeletal and cardiac muscle injury, which can lead to arrhythmias. These burns may show very little external evidence of damage. Thermal trauma due to closed space flames is likely to be associated with airway damage. Airway management in burns. In the initial phase of a burn, respiratory distress is usually caused by damage to the pharynx or trachea. Suspicions of airway injury should be high in patients that have facial burns, soot in the nose or mouth, singed facial hair, or if they're hoarse and they're coughing quite a bit. Obviously, administer the highest possible concentration of oxygen by face mask to these patients. In patients with major burns or who present with respiratory distress, hypoxemia, hypercarbia, or altered mental status, endotracheal intubation is indicated. Be aware that even if patients present initially in no respiratory distress, airway swelling can progress rapidly, so have a low threshold for intubation. Let's talk about carbon monoxide toxicity. In patients with smoke inhalation, always have a high suspicion for carbon monoxide toxicity. Carbon monoxide is a toxic gas, but it's colorless, odorless, and tasteless. It has a 200 times greater affinity for hemoglobin than oxygen. Therefore, it shifts the oxygen dissociation curve to the left, making it harder for hemoglobin to unload oxygen to the tissues. Ultimately, carbon monoxide toxicity produces tissue hypoxia. Remember that a normal pulse oximeter saturation does not rule out carbon monoxide toxicity. You need to measure carboxyhemoglobin levels with co-oximetry. What are some symptoms of carbon monoxide toxicity? At blood carboxyhemoglobin levels of less than 50 to 20%, patients usually present with headache, dizziness, and confusion. At 20 to 40% blood carboxyhemoglobin levels, a patient may become nauseous, they may start to vomit, become disoriented, and their vision may be impaired. At higher levels of 40 to 60%, patients become agitated, combative. They may even go into coma and shock. At greater than 60%, blood carboxyhemoglobin levels has been associated with death. What is the treatment? It consists of applying high concentration of oxygen, which promotes elimination of carbon monoxide. 100% inspired oxygen decreases the blood half-life of carboxyhemoglobin from 4 hours when on room air oxygen to about 60 to 90 minutes. So, therefore, hyperbaric oxygen is recommended for patients with carboxyhemoglobin levels of greater than 30%. Cyanide toxicity. Cyanide is produced by incomplete combustion of synthetic materials. Usual clinical presentation is unexplained metabolic acidosis. The definitive diagnosis is made by blood cyanide levels, and it's usually toxic, above a blood level of 0.2 milligrams per liter. Nonspecific neurologic symptoms such as agitation, coma, and confusion are present. High levels can cause cardiovascular system depression and arrhythmias. Therapies for cyanide toxicity include amyl nitrate, sodium nitrite, and thiosulfate. However, since the half-life of cyanide is so short, approximately an hour, it's thought that not much is gained by using these therapies. How do we fluid resuscitate these burns? Numerous formulas have been developed to aid in resuscitating the burn patient. Fluid of choice is usually crystalloid, specifically LR. The most well-known formula to calculate the fluid resuscitation is probably the Parkland formula, which is based on the percentage of body surface area burned. In the first 8 hours, resuscitate the patient with 2 mLs of crystalloid per kilo per body surface area burn. In the next 16 hours, replace with 2 mLs per kilo per body surface area burn. For pediatric patients less than 20 kilograms, you want to aim for 3 cc's per kilogram per body surface area for the first 24 hours. Half of this calculated volume is given during the first 8 hours. the 25% given during the second 8 hours, and then the remaining 25% is given during the last 8 hours. Endpoints for resuscitation include mean arterial pressure greater than 60, base deficit less than 2, and aim for an hourly urine output of half a cc to a cc per kilogram per hour. So what do we do when these patients come in the OR? As with trauma patients, keep the OR as warm as possible. Burn patients become hypothermic very quickly. With burn patients that come in the OR for extensive excisions and grafting, aim for 2 large bore IVs, plus or minus a central venous line, arterial line for close monitoring of blood pressure and frequent labs, hot lines for your fluids, cooler of blood in the operating room, warm the OR bed and all fluids going into the patient. Remember that burn injuries cause upregulation of postsynaptic neuromuscular junction acetylcholine receptors, ultimately leading to resistance to non-depolarizing neuromuscular blockers and sensitivity to depolarizing neuromuscular blockers. Avoid succinylcholine in burn patients that are greater than 24 hours out from their accident. Using succinylcholine can lead to hyperkalemic response, resulting in VTAC, VFib, and ultimately cardiac arrest.